Hi, good morning, everyone. Good morning. Please, let's just close our eyes as we take our prayer. Father, in the name of Jesus, we thank you this morning. We thank you for gathering us this. We pray, Father, that be in our midst, even as we are about to learn and share ideas. We pray that may this program, may this meeting go a long way to improve upon our professional experience and the work we do. Pray that may everything go well. In Jesus' name have we prayed. Amen.
Amen. Thank you, Aldi Abdallah, for the powerful prayer. In every home, there is always a father. And this morning, we are so privileged to have our president in our midst. We all have to hear a word from him and know the purpose of this gathering. So, ladies and gentlemen, I'm very honored to present to you our president, Mr. Haruna Seyid. Let's welcome him.
He used the word president. I'm the chief servant. I haven't accepted the chief servant and the president. Now the city president is Anyway, good morning to you all, my colleague brothers and sisters in the fraternity. That is the fraternity of GAND. On behalf of the Southern Zone, so actually the chief servant of the Southern Zone, with the support of all the entire team and my big boss here, whom you have interacted mostly. I think this is the first time some of us are meeting, even though we had the opportunity to have spoken to each other, or I had communication via the Zoom meetings and other sessions we had. Today is an important day because it's one of the first one-on-one CPD session that is hosting as a Zoom. It is my hope and prayer that this session goes well and we are able to build our capacities in those areas or selected topics so that we'll be able to impact positively at our various workplaces. Like he stated, my name is Zaid Haruna, but everybody calls me Zaid. So the Zaid, the only 4-letter word that you can get. So I'm a researcher with CSIR at the head office and whatever research at all. Anytime you are around that area, you know, finding it. I'm the most popular person because of the phone. Oh, the problem I am policing them. Anyway, I'm the administrator for the ethics committee for the entire CSIR and the research fraternity. So I have to police them to do the right thing. Some of these topics that we are going to be dealing with are so sensitive to the sense that it affects the lives of the people that we come into contact with. I always tell people that anytime you take an initiative to do something, you should think about 3 basic things. What I'm going to do, will it contribute to the improvement of life in where I find myself? Will it harm anybody? What will be the alternative? If these 3 questions are answered positively, then you are good to go. And once you begin to have second guesses around what you are doing, please seek consultation and seek advice from other professionals who are around. And this platform is still giving us an opportunity for us to network. Let's get to know ourselves. Don't come here with your friend and sit at one place. Sit with another person, get to know another person. I like to consult people a lot. When I'm doing something and I find myself wanting somewhere, I just pick a phone, call someone. The Lord will tell you that I'm disturbing me a lot. I can just call him, hey, I'm doing this. But I don't get it. What can I do? Then give me this viewpoint on that. Please, let's try it. It will help us a lot in our work. All right. Thank you very much. And I will leave you to the organizers for us to start the session. Thank you.
Thank you. Let's put our hands together for our chief servant. So we'll be moving on to have our first presentation. And before I call the resource person to do this, I want us to have an idea of who he is. Dietitian Priest Baby is a GAND governing board member who is responsible for the practice standards and accreditation of members. He is currently pursuing his PhD work at the Department of Nutrition and Dietetics, School of Biomedical and Allied Health Sciences, University of Ghana at Korle Bu. He holds an MPhil in dietetics from the University of Ghana and a BSc in biochemistry from the Kwame Nkrumah University of Science and Technology, Kumasi. Prince also holds a postgraduate diploma in nutrition in changing global environment from the Hebrew University of Jerusalem, Rehoboth, in Israel. He is an alumnus of the prestigious African Nutrition Leadership Program, organized by the Center of Excellence, Nutrition Western University. Some of the words are so big, in South Africa. Prince works with the Ghana Health Service as the head of diet therapy unit in the General Hospital. He has practiced clinical dietetics for the past 14 years. He runs regular nutrition outreach campaigns for schools, corporate organizations, and social groups. Prince is passionate about the nutritional health of individuals with diet-related diseases, as well as the general public. His professional goal is to ensure that every food on the plate or drink in the glass of his patients or audience is healthy. He runs therapeutic cookery seminars for hospitals, catering departments, corporate organizations, families, and friends. Prince runs the Diet and Diet Consult, which is an important vehicle for healthy nutrition advocacy, dietetic consultancy, and health food supply. Prince served as an executive member of the Ghana Dietetic Association from 2010 to 2018 in various capacities. He was instrumental in the process leading to the formation of the Ghana Academy of Nutrition and Dietetics. Ladies and gentlemen, I present to you our learned colleague in the person of Pastor Baden Priest. Hallelujah. Let's put our hands together for him.
All right. Thank you so much. Thank you for your kind Ivan, thank you very much. And as Apostle Paul would say, I am what I am by the grace of God. All right. So I want to say a very big thank you to the zonal executives, David and the team. Thank you for deciding to choose me to speak on, in fact, a rather tough subject. Diabetes and the current trends. You have to learn a lot, especially when you are speaking to very learned colleagues like you and those online. The way I had wished to meet all those online, I can't see your faces, but I want to say good morning to you all. All right. Okay, so I think we can start. The way the presentation will go, it will be very interactive. I'll post some intermittently and we'll talk so that we'll be able to get the input from whatever the leaders give me to talk about. I'll sit down for a while. When the heat goes up, I'll be on my feet. And I can control it right there. All right, so medical, this has been a back and forth thing. It's been appearing on our various platforms, and United States or even the UK, where the practice, if you have not done, anybody who is registered to practice in the hospital must have done the dietetic program. Ghana has a particular or a unique opportunity where the system itself has given us what we call the leverage to specialize. So we have the Ghana Health Service and the Ministry of Health employing people to work as nutritionists, public health orientation in the Ghana in the health sector. Then we have people
employed to work as dietitians, as in to take care of the medical nutrition therapy of cases in or outpatient. In fact, last year we spent a lot of time to develop what we call subspecialties in nutrition and in dietetics. So even though the public health nutrition in the hospital is a specialty and dietetics is a specialty, we still have the pediatric, the diabetes specialist, we have the critical care dietitian. So we have a lot of subspecialties under that we are developing. So we look at ourselves as GAND and say that is this system that has been running, does it work for or against us? We realize that it works for us because in every hospital you will see that the government will still have to employ a nutritionist and employ a dietitian. It helps us. Otherwise, if assuming we were doing one course, that they will just pick one person to be a nutritionist or dietitian, you realize that you just need one person to be in a hospital, and the rest of the people will be marking time. Even now that they employ both, we still have issues. So there's no context. GAND, we must have a clear mind. There's no context of is a nutritionist a dietitian or is a dietitian a nutritionist. These roles are eternally defined. Okay, I've been working with Joyce in General Hospital for a while. The work that she does, even if she gets a subspecialty, she will do so that she will just go to another corner. The work is so huge. It's too huge for us to be fighting. So when an issue comes, somebody said, oh, this one you cannot do because you have not done the dietetic program. This one you can do. All of us know what each one can do. I don't think it's something we have to fight about. Everybody and their practice. In fact, those who even did the dietetic program and they did not go ahead to do the intensive and even practice, they cannot be licensed. Then let alone anybody who hasn't seen any medical nutrition case before, who says, oh, we should allow everybody to do whatever anybody can do. Nutrition is a big family, and I think that the GAND agenda is a good agenda for us. We must major on our strength. I can't imagine 13 years ago, the General Hospital didn't have nutrition units. So if at this stage, now we don't have any nutritionists in the General. Yeah, three nutritionists. So all the work you were doing, that's what we were doing. Dietitian was doing all together. I can't imagine what would have happened to us. Maybe I would have become older than I am now. Right. So the work is huge, and our focus has been defined. Let's concentrate. I'm a dietitian, but when I get a serious problem with kidney disease, I'll call my colleague Ernestina because she has done a lot more work there. Right. So this one is just an appeal to all of us. There's no need for us to be. I've done nutrition for 4 years. I can do what the dietitian do, or you can do. The fact is that if you are able to do whatever you are saying you will do, you are helping people, please go ahead and do. But when it comes to the accountability, and maybe something happened, they call you to a panel, then you realize that you might have done so much. Even the little that you have to do, you might have left it and you are doing another thing. Let's focus on what we are doing. Let's do it well. If you are in school health, do the school health well. Community service, do it well. So that, and build yourself in the current research day, so that you become an expert. So that's what I will say before I continue. Thank you very much. I'm saying this because a lot of things come to us, especially because of where I sit. But let all of us be at peace. We are colleagues serving the country for us to be healthy in our nutrition endeavors. All right. Okay, so Abdullah, please be attentive so that if there are any reaction from the or comments from those on Zoom, you can No, should I use mine? It's not moving. Is it yours? Please, those of you on Zoom, will be with you. We want the slides have frozen. We want to work on it so that we can all be on the same page. I can also join presentation. Hey, officer, I salute. Yay. Hadia, you are not a small woman. You have officers working with you. Okay, you yourself, you are above Kenya, so a step ahead. Can I use mine? So I present. I think if I join, make me co-host. Even if it will come small like that, it will grow. All right. Thank you. Thank you so much. So we have two presentations today. When I'm done with my our sister, Mrs. Kisi, will also take us to the second topic. Right. So this is the outline. We'll be talking about. I'll introduce the topic shortly. Then we'll do an overview, a short overview of diabetes. Then I'll talk about the underlying evidence for medical nutrition therapy. Then I'll conclude and I'll set in motion discussions. Fortunately, I've asked everybody's name here. So, and I have those on Zoom too. So I'll ask them questions, then we'll discuss. All right, so we can now move. So it is the International Diabetes Federation estimates that's the report in 2021 estimated 537 million adults with diabetes mellitus, and 6.7 million died as per the report. Then 3 in 4 adults with DM or diabetes live in a low and middle income country. And right now they say we are middle income, right? So we are part. Then, so it tells us that the diabetes issue is a grave issue. When we were training in dietetics, the percentage was so low, even in the global sense. It was very high in the North and Southern America and in Europe. Right now, it is getting very scary. If you look at the prediction for 2030 and 2045. So the IDF report states that there will be an increment to 648 million people with diabetes by 2030 and 783 million by 2045. And look at what is in the black, the middle. Less than half of people living with diabetes in Africa are diagnosed. So the diabetes situation is worse globally and is bad globally, but worse in Africa. So the cost of management, now we are trying Ghana Health Service, health insurance, they are taking it, they take it up. So when somebody is diabetic, but some other auxiliary medication they may have to buy. So you have many people, even the small amount they have to pay to be on the health insurance, some are not even able to do, and many more people are not accessing the healthcare for diabetes, and because of that, it's causing or it's making the case worse in the low to middle income countries, including Ghana. We have the medical nutrition therapy being a very critical tool in helping people with diabetes to live well. And normally, this is using the food that the people eat and combine the nutrients for them so that it will help them to be able to live well. A lot of research are being conducted now that are giving us a lot of hope. We are having some remissions in diabetes, those who have been diagnosed earlier on in their progression. And we are seeing that if medical nutrition therapy is adhered to strictly, and in cases that we will see as we move on, you realize that it has helped many more people. And because people would, by all means, eat, when we take a serious note and a serious interest in medical nutrition therapy, we'll be able to help many more people, looking at the problems and difficulties we have across Africa. Now, so let's do a quick overview of diabetes. I know that the assumption is that all of us here, we know diabetes, we are taking care of diabetics already. The dietitians here, you are providing medical nutrition therapy. So this presentation is just to see some new things that we can add on to our practice, right? So I'm not going to go to the first principles in this presentation. So we know that diabetes is a chronic disease, and we know that it's about insulin, whether insulin is absent or a little insulin is present, or insulin is ineffective or it's not functional, right? So this is the ideal definition. And we have three main types, even though there are several other types we'll talk about: type 1, type 2, and gestational diabetes. These are what we know now, and that's what we normally refer to as the ominous update, the threatening 8. So 8 different defects in sugar metabolism are identified. So diabetes is not like malaria that Plasmodium has entered us and it has gotten somewhere. Then it's one target. We just get anti-malaria to target either in the liver or in the bloodstream, then we are done. Here, we are having a problem with a lot of enzymes and activities of some genes. So we have decreased incretin effect when you go to the GIT in the intestines. When it comes to the pancreas, we have an issue with the pancreas. We are having an issue with the liver. So the diabetes situation affects at least 8 organs. That is how come its management it's taken very seriously, and a plethora of people in the health sector are brought together to help us solve the diabetes issue. So we have the brain contributing to it. The muscle uptake of sugar by the muscle is also reduced or non-existent. We have the kidney, the glucose that it has siphoned out that must be taken out is reabsorbed into the bloodstream in an abnormal manner. So diabetes is actually what I define a group of diseases which share a common characteristic, and their characteristic is what? Hyperglycemia. So you see that the pancreas, the GIT, the kidney, the liver, the muscles, the white adipose tissues, all of them are defective because of this diabetes and resulting in elevated blood glucose. So, having spoken about this, I just want to refresh your memories about the other types of diabetes we have as identified by the WHO. So we have the hybrid forms of diabetes. So this category alone has subcategories, hybrid forms. We have the slowly evolving immune-mediated diabetes of adults. It's slowly evolving. This is not part of type 1, 2, and 3, type 1, 2, and gestational. We have the ketosis-prone type 2 diabetes. So these ones are what the consultants, the diabetologists may finally delineate from the usual type 1, 2, and gestational, right? We have the other specific types, the monogenic diabetes, the diseases of the exocrine pancreas, the endocrine disorders, which result in hyperglycemia. So you can, and unfortunately for us as dietitians, you will have, maybe the best you may have is type 1, type 2. This person is having elevated or is diabetic. The glycemic index is, the glycemic control is very poor. It's always hyper. You are trying to feed, you have cut your carbohydrate even to 130 grams, and so the sugar level is high. Sometimes there are other things happening, right? So we have the unclassified diabetes. So the other ones that are not classified. So very soon, when a lot of these work are completed, we may have to be re-educated again because a lot more things are coming up. Then we have the diabetes. So we have diabetes mellitus in pregnancy itself. So it's not that the person was diabetic before getting pregnant. And it's not that she's diabetic because she's pregnant. But she's diabetic. And it occurred when she, in the course of the pregnancy. It's not that the pregnancy brought it about. But it would have happened anyway if she was not pregnant at that time. So that's diabetes in pregnancy. So that's one to there. So this one is for us to think about. So if you are seeing any case that is so challenging to you, you have done all that you do, prayed all the prayers you can, and nothing is happening, you must know that you have to collaborate, see the endocrinologist. If you have some facility, discuss with them and see whatever you could do. And this one also opens the door for a lot of those of us who want to do masters in dietetics, PhD in dietetics, a lot more areas for us to consider our research. So medical nutrition therapy for diabetes mellitus, the underlying evidence. I want us to be very attentive here because maybe our feathers may be shuffled a bit, but let's see what happens. So we know that nutrition is key, and everybody will say it. Nutrition is key for health, key for life. Nutrition is also key for diabetes. And nutrition recommendation for diabetes must be well grounded and founded on research so that we will not just be saying our minds or just doing something like, I think Tina is here. When we started, when we were, I think, first year in 2006, you go and say, okay, go and eat this food and come back and let's see how it affects. See, so a lot of work had not been done even on our indigenous food. So eat and let's see, try and error. But even that one was better than people who were just eating, right? So this is the opening comment in American Diabetes Association. They are documents for management of diabetes. So medical nutrition therapy. So that's nutrition management of diabetes. That section of their document. Medical nutrition therapy is an integral component of diabetes management. Integral component of diabetes management. I know that you may work in facilities where some medical officers would want to treat with medicine when it's not getting better before. Okay, go and see the dietitian. Let's see what they can do. I don't know whether anybody has experienced that. Yes. So, but this is what ADA says. Said it's very integral part of the management of diabetes, especially the self-management education. And yet, many misconceptions exist concerning nutrition and diabetes. So, in clinical practice, nutrition recommendations that have little or no supporting evidence have been and are still being given to persons with diabetes. So sometimes somebody gives a recommendation, says, what is your basis of this? So I feel like I've been using it and it helps my people. You know, until we are sent to court one day and a senior dietitian to you is brought and asks, will you do this to your patient? And the dietitian says no. Then you see that your feelings does not matter. So what are the goals? So in preparing for this, I had to assess the American Diabetes Association, the WHO, the medical nutrition therapy as espoused by WHO, American Diabetes Association, International Diabetes Federation, British Dietetic Association, and so that I can put something together that we can relate to. Some of the things will still be a bit foreign, but you will see how it must challenge us for us to have our own. Me as a chair of practice standard, actually, I get worried that as of now, we still don't have ours. Okay, we are trying. A lot of work is being done on that level as well. So the medical nutrition therapy for all these bodies are what we have brought together to find out the goals for MNT. What are the goals? The key goals are that we have to attain and maintain optimal metabolic outcome. Optimum metabolic outcome, because we realize when you see the paraphrase definition I gave, diabetes is actually a group of diseases. And their aim is to make sure that your sugar level is always high. So it affects the whole metabolic state of the person. And your goal in giving any food, drink, fruits, vegetable, or water to any patient of yours is to attain optimal or maintain optimal metabolic outcomes, including what? Blood glucose level, lipid and lipoprotein, then blood pressure. So the diabetic in front of you is not a one-sided case that somebody just came with. If somebody comes with lipids, high lipids, somebody comes with pressure, it could be even the foretaste of actually the bigger problem, the diabetes, because it may come eventually. And if the person actually has come with diabetes, then as a dietitian sitting and going to give medical nutrition therapy, you must see that the problem is huge, so that you will not take it for granted, right? So the second one is to prevent and treat the chronic complications of diabetes. Now, so one, some people may come that the chronic complications of diabetes are evident. So somebody is coming, they are losing their sight, they are losing, their kidney is failing, and all those ones. So that's one we try and manage their complication. But those newly diagnosed that have come to you, we try as much as possible to prevent the onset or delay the onset of the complications. So by preventing and treating obesity, checking that the lipids are not high. So if somebody came and the person has hyperglycemia and the lipids are fine, the pressure is fine, you still have to factor all those in your counseling. I think we are taught that, so that we don't wait for them to come before we add to our counseling. We have to improve health through food choices and physical activity. So we actually have to engage the diabetics. The goal is to get them to commit to healthy food choices, and also address individual nutritional needs, taking into consideration personal and cultural preferences and lifestyle. Right. So we have goals for specific situations in diabetes. So we have the young people with type 1 diabetes. So the youth with type 1 diabetes, how do we provide adequate nutrition? The person is still growing. The person is 12 years, 13 years, 14 years, very tall, very slim, needs high calories, how do we provide the person with adequate energy without necessarily that will be fit for his insulin regimen, so that the person will manage the hyperglycemia and also grow and will not be having episodes of hypoglycemia. So, but then we have youth and even children who are having type 2 diabetes as well. So how do we help them? There are people who are 87 kilograms, class 4, class 5. They have type 2 diabetes. They are still growing. They have diabetes. How are we going to take care of them? So those youth with type 2, we have to facilitate the changes in their eating and physical activity habit so that we can improve on insulin resistance, right? Then for a pregnant woman and lactating women, we have to provide adequate energy, nutrients needed for optimal. So how do we provide adequate energy without compromising on the sugar level and also not compromising the quality of life of the mother or the pregnant woman? So older adults, if the person is an aged 65 and above, how are we going to exempt them from all their foods like we do to the young people? We must provide the nutritional and psychological support. There are some foods when you take it away from the older clients, the person will die early. So a lot of work, we must have patience and make sure that the goal is that the person's quality of life will not be so much affected, and that we can do a plan for the person that will let that given adult to be happy and live in peace. So individuals that are on insulin as well and other diabetes medications, we must ensure that our meals are congruent to their medication. There are several times that, in fact, it used to happen to me when I started practicing, that I gave diet without regard to the impact of what the medication on the food. So you give them, you say 2 weeks, those days we used to give 2 weeks. They can say that I'm not able to sleep. I hear coming dimmy. You look at it, what medications are you taking? So I'm taking metformin. Is that, oh no, I'm also on insulin. The person is on metformin and insulin, and you give 1,600 calories because the person is fat. You may kill the person before you come for the next review. So the goal is to be sensitive to whatever they are using to support uptake of glucose from their blood. Very important. Then number 6, for individuals that are one parent is diabetic, the person is hitting 40, he has come to see you, right? So these are special group. He knows that he has read about it, that because of genetic reasons, he or she may get it. What do we do? The goal is to decrease the risk by encouraging physical activity and promoting healthy food choices and getting healthy meal plans for them. Now let's come to the nutrients, because we said that medical nutrition therapy is combining food and nutrients to treat, to prevent, treat, or manage conditions, right? So we see that there are some words we use. Carbohydrates. We have something like simple sugars, complex carbohydrates, fast-acting carbohydrates. The work that the American Diabetes Association did found out that the terms were not really understood, were not defined. They did some survey among dietitians. When you say simple sugar, what do you mean? And when you say complex carbohydrate, which foods consist of that, or which type of carbohydrates are complex? So they came to the recommendation that let's use sugars, starches, and fiber. So you say take carbohydrate food that have a lot of fiber. Example, this. So take complex carbohydrates. Sometimes you forget that to even explain to the people that in our minds as dietitians, complex carbohydrates are carbohydrates that are not refined, that the fiber are still inside. But when you talk to a few people, or a group of people, you realize that everybody have their minds. And some food that you say is not complex, another person say, oh, but this one too has fiber, it's complex. So they say it is for easy communication. Sugars. So you mentioned sucrose, fructose, this, starch, your starchy foods, plantain, cocoyam, cassava, this. You talk about your cereals, then your fiber. I've also found, and this one is also with the what I gleaned from all the four, was that foods that contain like a lot of fiber, cereals, fruits, and for us in tropical Africa, our starches. So the cocoyam, the taro roots, the plantains, the yams, they have been found to be helpful when they are chosen and eaten rightly. Right. So glycemic index. Another, I think by now, many of us have known that it is not, and the work that our colleague Divine did in his master's showed us that glycemic index alone is not really the matter, because when the food are put together, the glycemic load actually counts, which is how does the food behave after it has been eaten together with the other ones, instead of how does it behave alone, right? So no convincing and consistent results are observed from comparative study with high GI food in type 1 and type 2. So let's say if somebody had type 1 and type 2 and you gave high glycemic index food to one and the other, the research didn't find any significant difference between the two, right? And also, not only that, for the general population, people with diabetes are encouraged to choose a lot of fiber. But also, I think this one, I didn't add the writer, but glycemic index, human study that had a patient fed with high glycemic index food in the company of other foods, compared to those that were given the quote and unquote complex starches, there was no significant difference between their glycemic output in terms of their glucose levels. So, subjects with type 2 diabetes, it seems to us that the large amount of fiber that we have from the vegetables, fruits, and our cereals and starches have been found to be very helpful. So they can eat the starches, they can eat the carbohydrates. But as per your calculation and your assessments, like we do for all patients, that is what we must do. I want to say here that the use of sucrose in terms of whether brown sugar, molasses, white sugar by diabetics have been an issue of. We have some history that many people who had seen dietitians for a long time were told no sugar, and they also told their children and their children's children. So when the studies are even showing a different result, we are still adamant, and sometimes it even affects practitioners as well. But we are doing the current trends, and we must take this one into consideration. People who were given carbohydrates. So let's say your client, you are going to give 180 grams of carbohydrates, and part of it was sucrose, and others were given other carbohydrates without sucrose. They virtually had the same glucose output once the total carbohydrate was the same. So ADA's position is that, so American Diabetes Association is that intake of sucrose or sucrose containing foods by people with diabetes does not need to be restricted because of concern about aggravated what? Hyperglycemia. That's why I put it in red. It is one of the things we will discuss when we come to the discussion section, whether we agree or disagree, and how has your personal experience at the clinic been, right? Okay, let's move on. So, ADA, WHO, and even BDA, they also recommend the use of non-nutritive sweeteners. So, the non-nutritive sweeteners that we have around, if people cannot eat their food and they needed their food to be sweetened, then we can give them. Right. I put that one to in red for our discussion. Right. Okay. From the biochemistry aspect, there are a lot of work that are being done on the non-nutritive sweetness. Currently, there are some works that are also being done. And I know many of you are well read in this area. When we come to the discussion, we'll talk about it. Or let me even pause here. Let me pause here. Anybody with any comment on the use of nutritive sweetness in your professional practice and your professional orientation? How have you been managing your patients? If they want to take it, do you advise them against it, or you tell them that it's okay, they can take? Any input from any of us? Okay. Okay, so can you read them for me? Read them on this. Okay, this one. Well, RD Prince, please kindly explain the hybrid and the new types of diabetes to me. I didn't get it well, apart from type 1, 2, and gestation, or type 1 and 2. Please explain the rest to me. Thanks. Okay, so let's move on. Then the down is what? Go up. Please, your voice is getting faint. I hope it's better now. Okay, all right. Okay. So glycemic index of some local food. Okay, so RD Agodo posted Divine's work. I think it's helpful. So those of you, I think the one managing for the inpatient, put it on the page. Yes. Forward it to the page so that those of us who are here, we can have access to it. Most of the patients, most of the patients don't what? I saw something. Yes, that's RD letter. Most of the patients don't want to use even sweetness. Excellent. So, like even the sucrose, many patients don't want to use it. But for us as practitioners, if somebody comes and says, "If you take my sugar away, you have killed me," you don't say, "Oh, meow, meow, meow." Right. Okay. Yes. Sir. Yeah.
You know, most of the SCs that we have, the private SCs. So if you have a patient who will tell you that take my sugar or my honey away from me, then what I explain the rationale behind, and then I'll ask the patient how much sugar you have.
Okay.
And then I can use a slice of bread or 2 slices of bread for that. So when I do that, when you use the 2 tablespoons of sugar in your meal, and then what And then with the sugar, just this one nutrient. And your bread now let's come to let's move up. Which one? Most of the time you get it, then maybe so that the one that has strong benefits. And there are some to let talk to the doctor. Tell the doctor this patient is especially for a that this patient will be up the insulin. And even they say how has that patient that what you have chakra, what you have your social what it means your budget for the situation you have. The inconvenience was not really for the joint as fast. So when you always in place, the client
All right. So thank you very much. So it comes to the point that the total carbohydrate is crucial. The amount of carbohydrate you are giving, so for diabetics, at least 130 grams of carbohydrate going, depending upon your assessment. So if you are giving 130 grams and you tell the person what it means, okay? So if a slice of bread is 20 grams and you are giving 130 grams, which is about what? How many slices? The whole day. The whole day. And the person says, okay, take 3 of the slices and give it to me like sugar. I'll prefer to take 6 slices of bread plus the sugar than to take 9, right? Once you are giving soups, stews, and other things, and salads in addition to this, the evidence is that when the carbohydrate level is not changed. So like Ardi said, you would have to explain to the patient that it's not your carbohydrate allowance plus your sucrose, but including your sucrose. If you explain to the person and said, oh, okay, I'd rather defer to you, fine, you have won a soul. Right? If the person says that I can't, if you take the sucrose out, I can't, make sure you work it out. And maybe up the vegetables or yes, okay. And when you put all the, especially for the aged client, how can you tell an aged client who had diabetes at 70 and has eaten his honey and sugar all up to 70? You see, that's why the goal for the aged client is to let them have quality food choices. So you come back to them, explain to them that maybe if they were pouring it, you may say, okay, measuring some is better than none, right? So, but even some of the aged, they themselves may say, I won't eat it again. You are fine and you are gone. But if they insist they will eat, please factor it into them. That's how come Ghana government trained you and made you a dietitian. Calculate it and give them food that will improve their quality of life. All right. There's a question. Rosa, some clients before they come to you have done their own investigation and therefore tell you they have stopped taking sugar without waiting for your response. Now, if a client says he or she has stopped taking sugar, I don't think you need to tell the person that you can take sugar. It's not professional. If it's like someone who doesn't take alcohol and comes to the WHO says you don't encourage anybody who doesn't previously take alcohol to take alcohol for any perceived benefit. Yes. So if the person says, we know that the sugar will make the food small anyway. The sucrose will make the food small. So if the person says, I don't take sugar, I've stopped. Unless he says that it's so painful, but I've stopped it anyway. That's why you know that the person may still take it, may hide and eat it. And when he comes, he'll tell you that he hasn't taken any sugar. So self-imposed exile. So those ones, we can help them and say, engage them further and help them to take that. All right, let's go. My time is almost up. Yes, during the question and answer session. So let's go on. Good. So how grounded are the various MNT recommendations inside? How grounded are we? So that if you are called on any panel, you can defend yourself, right? I always tell my colleagues at the General that even the diet sheet pattern we have done, if you are giving the diet to anybody and you are not so confident to defend any part of it, cancel it. Because when they call you, you are the one who go and defend. Is that okay? So we must say what we can defend. All right. So the American Diabetes Association, together with them, most of the things they espouse and encompass all the others. That's how come I normally quote them. Diabetes, their standards of medical care in diabetes is updated and published annually in a supplement to the January issue of Diabetes Care every year, right? The standards are developed by the ABS Multidisciplinary Professional Practice Committee, including diabetologists, endocrinologists, dietitians, and pharmacists, diabetes nurses, and all those ones. They form it together. The standards include the most current evidence-based recommendations for diagnosing and treating adults and children with all forms of diabetes. So the evidence are graded A, B, C, D, A, B, C, and E. A, B, C, and E. So these are the levels. If it's A, so when any recommendation is graded A, it means that that recommendation is based on a clear evidence from well-conducted, generalizable, randomized control trial and are adequately powered. So when we say the research is adequately powered, it means that it was done with enough sample. The sample size was enough, and also it's B. When it's graded B, the supporting evidence from well-conducted cohort studies. So if it's a cohort study, a research has been done. It's not as high rank as a randomized control trial, but it could be used for practice. So that's B. C is supportive evidence from poorly controlled or uncontrolled studies. So some studies have been done, but it was poorly controlled, but at least some outcome has come out of it. So it is chosen above somebody using their mind, right? Then the E is expert or consensus of clinical experience. So when you see that the evidence is rated E, it means that it is from, let's say, ourselves, dietitians in Ghana, from our experience, this and this and this. Okay, let's go this way, right? So level A evidence for carbohydrates. Foods containing carbohydrates from whole grains, fruits, vegetables, and low-fat milk should be included in a healthy diet. So here, where you see whole grains in sub-Saharan, we say starches. We add it to the whole grains, okay, because they don't have much starch in it. But quite some work has been done with our starches here, so we are confident in that. Then with regard to glycemic effect, we've discussed that. The total amount of carbohydrates in the meals or snack is more important than the source of all type. I think this is an emphasis. So, but that does, you see, so the stretch question is, does it mean you can just calculate the person's meal from ice cream, toffees, this, that is an absurd assumption. We know what a healthy meal is, and we know the composition. So when we say the total carbohydrate is more important than the source, it doesn't mean that the source that we know flashes the system, and also other evidences show that they also cause other problems to the body, must be ignored. No, it's a comprehensive care we give. So every knowledge we have about every food. So let's say if somebody, you are giving sugar, sucrose, we know that sucrose is linked to dental caries, for instance. So you will not say, okay, now, so I'll give sugar, sweetened beverage, plus sugar, plus honey, plus toffee, plus ice cream. That is what the person likes. You might have met your carbohydrate requirement, but you will cause other problems for your client, right? Even though the sugar may not rise, but the person's teeth, the person may lose all the teeth or be in pain. So non-nutritive sweeteners are safe when consumed within the acceptable daily intake levels. So ADA accepts it that if the person, if there's the need for it, 1 or 2 tablets or 1 or 2 sachets, they accept it. And I think in Ghana, we haven't come with any position against it yet. So level B evidence is that individuals receiving intensive insulin therapy should adjust their pre-meal insulin doses based on the carbohydrate content of the meals. Okay. So if the person is going to give the insulin, then if you are giving 15 grams of carbohydrate per shot of insulin, then the person can adjust. I'm going to give maybe 10 units. So the meal before that food could be adjusted to meet the number of units, right? So this is a level B evidence. What it means is that when you are planning you are doing your plan for your patient, you could consider it, especially if you have done your dietary history and you see that the person has been eating bulk amount of meals. You can shift and rearrange that the bulk amount gets closer to when the shot is given. Okay, so and there is a quite reliable evidence for you to base your decision on that. The glycemic index thing, we have dealt with it, so we can move on. So as with the general public, consumption of dietary fiber is to be encouraged. However, there is no reason to recommend that people with diabetes consume a greater amount of fiber than others. We normally used to say, Mrs. Owusu of Blessed Memory, the former chief dietitian of Ministry of Health, he said that the best meal or the healthy meal is the diabetic diet. Right, so the meal, a balanced meal, aside from issues we have with 1 or 2 cases where you may have to really reduce the carbohydrate levels, the 40% to 65% range normally works for many clients. But then there are instances that you may have to have less than 40% carbohydrate of the total calories for a client because of your assessment, right? So he says that people can go and buy fiber and add to their food. When they are even drinking water, they may want to even add fiber powder, fiber to it. He said that there's no evidence to that. It's a level B evidence that if you are diabetic, so pile yourself with fiber. No. Let the person enjoy their food. Let their food be healthy and balanced, and adjust their carbohydrate as per your assessment, and that is fine. All right. Protein recommendations. You see that proteins, the evidence begins with evidence B, level B, right? Because a lot of work at the higher evidential level really will tell you that yes, proteins affect glycemic levels or glycemic control, but after protein is eaten, the expected effect on the blood sugar is not that high. So that is why when we give very low carbohydrates to people who are rather even pushing for remission, you will see that we increase proteins, but their sugars don't rise. Their sugars don't rise. So we said in persons with controlled type 2 diabetes, ingested protein does not increase plasma glucose. Once you calculate it within the recommended energy or calories, for persons with diabetes, especially those not in optimal glucose control, the protein requirement may be greater than the recommended dietary allowance. Wow. I was happy when I read this, but not greater than usual intake. So the importance of dietary history now comes in here, right? So if you can increase the protein whilst reducing the carbohydrates, it helps. But then you cannot increase the protein beyond what they told you they have been eating. Right? Okay. Expert consensus on protein. For persons with diabetes, there is no evidence to suggest that usual protein intake, that's 15 to 20% of total daily energy, should be modified if renal function is normal. Is it clear? Because we know that protein intake is what? What is the range for a healthy meal? Protein. The range. Not per, I mean for the percentage of total calories. 15 to 30. 15 to 20. Or 10 to 20. Remember when we were training, it was 10 to 15. It was 10 to 15, and now it has been upgraded that you can eat more proteins. So we said that the 15 to 20%, we may not modify it if renal function is normal. Okay. The long-term effect of diet high in protein and low in carbohydrate are unknown. So still there are cohort studies going on, randomized control trial going on with how long, what's the long-term effect of low carbohydrate, high protein, high fat. Okay, but at least we have expert consensus that it has not affected our patient badly. So we can go ahead and do it until a higher or a better evidence comes. This is the case for our CPDs. So if the evidence comes next week, next CPD, you must be here, otherwise you'll be killing people. All right. We are close. Yes. Yes. The second point. Hey, sorry. Next question.
No.
So for the second, after increase evidence showing that and then added that this is that we have serious life issue.
Yes.
And then we cannot increase more than what the patient tells you. What about if the protein the patient after the lunch realize that
Was rather low.
it is rather low?
Yeah. Yeah. So so he said this is the point. The persons with diabetes, especially those not in optimum glucose control, the protein requirement may be greater than the recommended dietary allowance. So if the protein we are giving 1.2 gram per kilogram, the person we may give 1.5. This is what this recommendation is saying. We may give 1.5, but not greater than usual intake. So the usual intake here, we define usual intake as per what we give per kilogram, the amount per kilogram for the standard body weight of that. Yes. So if there's 75 kilogram for male, 70 for maybe female. So then if it's 1.1 or 1.2, we are doing 1.2 times 70. That would have been the usual intake. If the person is taking 30, it means that we will have to go up. You have up to within the okay. So here I think I misapplied the usual intake. The usual intake is not what the person has been eating. It's scientific. It's scientifically calculated. Yes, the amount as per kilogram for the ideal body weight. Yes. Yeah. Thank you so much. That's why you have to be here with sharks. So we can go for fat. Less than 10% of energy intake should be derived from saturated fat. And at first, it used to be made. And it looks as if we have been demonizing saturated fat. Saturated fat are also needed. They are not to be totally exempted. But can we even, especially those of us in tropics? So, in calculating the amount of saturated fat, usually it will be from our tropical oils. We will not, the saturated fat, we are not talking about deliberate saturated fat from animal foods. You may do lean cut of proteins, but you may still have snippet of fat in there, which may contribute 1 or 2 grams of saturated fat. But your total fat you are giving, if you are giving 100 grams of fat, 90 grams of fat, about 9 grams could be saturated. No, not could, should be saturated. The evidence had been may or could. Now the current trend is should. But I think it makes sense because saturated fats are also needed in metabolism. Right? So it makes sense. Dietary cholesterol intake should be less than 300 milligrams per day. Less than 300 milligrams per day. So can your diabetic eat egg? Whole egg? Yes. How do you eat Tina? Yeah. Yeah. Yes. Okay. Yeah.
And you want to just take 2 sticks
And it fits
and
into
we will
the
say don't take it. Take coconut oil. Then I think restrict the use of mayonnaise and those things. And because of that, some people find it difficult to eat vegetables. So if it falls within, why not?
Yeah. Yeah. So as our calculation. And look at the one that the recommendation, less than 300 milligram cholesterol. It gives you one hope of using saturated fat. It comes to tell you, because if you look at the 300 milligram cholesterol, it's small. One egg is 250. One egg yolk is 250, right? 250 milligram. That's one yolk, right? So it means that if during the day the person took an egg home in the morning for breakfast, which normally people don't take one, but if it was one, if it was one, we are almost done with the cholesterol requirement. So then it becomes difficult for the person now to be giving butter again. So then it can, like Aldi said, you can say, okay, you can have butter days, yolk days, because as for the egg, it can be eaten. But as of whether the yolk should be part or not, that could be discussed with your client based on your calculation. So for me, sometimes I think it's for all of us, when we are called on air, And we are, can we, I don't answer can we questions on head. Can we eat this? Can we eat? In fact, everything is, it depends. Everything is, it depends. So that they don't use us for their jingle, right? The dietitian said, you can't eat. The dietitian said, yes. So it's a plan. That's how come we sit with the people and talk. And that's why you do your calculation so that you can get it. All right. Let's finish it. So to lower LDL cholesterol, that's evidence B. Right? No, but let's look at this. We said persons with LDL cholesterol greater than 100 milligram per deciliter may benefit from lowering dietary cholesterol to less than 200 milligram per day. So assuming even before you saw the diabetic, the lipid profile is already deranged, then even this 300 thing becomes smooth. You get it? Because you want to remember the goal. Moderate lipid profile, help with blood pressure. So you are looking at all the other angles. So that's how come when anybody comes to me who has seen another dietitian and we say, oh, the dietitian said I should stop egg, I should stop it. I said, oh yeah, I think it was needed at that time. You see, because until you have all the fact the dietitian had, you have no basis to passing judgment. Right? Because the person came to you with hyperglycemia of maybe 8.1. Oh, it's not that bad. The person went with HbA1c of 11.2, lipid profile total of 9, LDL of 7. The person has come to you with none of them except 8.1. So, oh, but why the dietitian was so mean to you? Sometimes we can diss ourselves easily, but we must be cautious. Let's look around, not only on the value of the sugar, but we must look around the other components as well. Okay, so level B evidence. Energy derived from saturated fat. Hey, battery low. Hey. Energy to lower LDL cholesterol, energy derived from saturated fat can be reduced if weight loss is desirable or replaced with other carbohydrates or monounsaturated fat weight. So it comes to the point that if there's hyperglycemia, if there's hyperlipidemia or dyslipidemia, the earlier recommendation of not greater than 300 milligrams of cholesterol could be amended. And always remember that the diet could have been you eating it. So also look at yourself that if you did this diet for yourself, right. Yes, Adi Mensa.
So, as part of the clinical management at the medical level, is a prescription team.
Yes. Yeah. Yeah.
So how far or how strict should be when it comes to dietary cholesterol? When the person is on this
Okay, so when the person is on routine atorvastatin or routine statins together with the diabetes medication, and the lipid profiles have been good for about 6 months to 3 years, but the sugar is still being managed. How far could your should be? I remember I always draw the attention of anybody on statin to, I think what is point? Is it one of the key points? Everybody on statins or cholesterol lowering drugs must be on cholesterol lowering diet. It's on the sheet that is in the statin, the Lipitor and atorvastatin. I've read it. Then I was asking myself, why are they saying that? Right? It's like You don't have to. Somebody saying that throwing rubbish there when he saw somebody sweeping, and the person said shouldn't throw it. He said, "But you are sweeping." No, you don't. You don't throw rubbish because the person is sweeping. You don't come and add more weight to it. So that is what I would say. It sweeps and moderates your lipid profile. But if it moderates, it's only for you to populate your serum with cholesterol. All right. So I think that that is not the idea. The idea is to prevent the people from having any attack. So if in the All right, sorry. Very sorry. We had a power fluctuation. And so we're talking about the evidence, strength in recommendation. Strength of fat, we said we've discussed that. Then the trans fatty acids should be minimized. So foods from the fried Okay. All right. So our recommendation about trans fat still stands. They are not. We don't encourage people to take a lot of. We must do our best to minimize it. Trans unsaturated fat. So the use of margarines, the baked foods, and fried reusable oils. The recommendation still stands. 2 to 3 servings of fish per week provide dietary omega-3 polyunsaturated fat, N3, and can be recommended. Fish. Level C evidence. Polyunsaturated fat intake should be approximately 10% of energy intake. And I think all of us know what they are. So, energy balance. Energy balance. So if the person is insulin resistant, we have to reduce energy intake, and there should be modest weight loss to improve insulin resistance and glycemia in the short term. So if the person's insulin is not responding, we reduce energy intake and modest weight loss. So if your assessment, the person is taking 2,000 calories, 2,500, you have to use your professional judgment and calculation to see the appropriate reduction. Whether you must come to 2,000 or 2,800 or 1,005, it must be, that assessment must be done. But there must be a reduction in the energy intake so that you can have some weight loss as well. Because weight loss has been linked to improvement in insulin resistance. So structured programs that emphasize lifestyle changes, including education, reduce fat and energy intake, regular physical activity, and regular. So exercise, weight loss, is key. It's still recommended. It's a level A evidence. So if you have a diabetic whose weight is high, you must have a weight loss projection as part of the management. So there's no clear evidence of benefits from vitamins. So this one, macronutrients, vitamin, mineral supplements in people with diabetes. So if people come and they say, "Oh, I've gotten this vitamin, this supplement. If I take," they say my diabetes will improve. We have no evidence yet. And sometimes, when we say no evidence, it doesn't mean that one single or two research have not shown promise, but they are not enough to come to have an evidential value to affect practice. So sometimes these people with supplement, they can say, "Oh, there was this randomized this year." They can pick 1 or 2, 3 research, and they will tell you that because of that, recommend it to your patient. We don't normally come to a consensus or influence practice with 1, 2, or 3 not well controlled research. Alcohol. I think I spoke about alcohol, that individuals who drink already should be limited to 1 drink for adult women, 2 for adult men. And they've given 12 ounces of beer, 5 ounces of wine, 1.5 ounces of distilled spirit. But if your client does not drink, you don't say, "Oh, even there's a recommendation." It doesn't improve. It doesn't improve. It will not improve the person. This is for people who are drinking already, and you have been taking 3 times, 4 times, 5 of this. Then you bring them to the amounts that give minimal risk. To reduce risk of hypoglycemia, alcohol should be consumed with food. So those who consume alcohol, after giving this amount, that amount must be taken with food. Yes. Special consideration for type 1 diabetes. Nutrition recommendations for a healthy lifestyle for the general public are also appropriate for persons with type 1. Please, I've seen some cases that people have prescribed very strict, low carbohydrate diet for type 1 diabetes. Please, type 1 diabetics, it's not their fault. The insulin just will not come, or even if it comes, it's too small. So they must, most of them are young, growing. They must grow. So like R.D. Hamda said, you and the doctor must be working together and be giving enough food for the person to eat. Give enough food, enough proteins, enough carbohydrates. The person must eat and grow. And we need the insulin to absorb the glucose into the muscle to effect growth. So you cannot give a diet without the insulin, or without having knowledge of the insulin and how the doctor has been changing and either increasing or reducing. All right. The slides will be given. So for persons receiving intensive insulin therapy, the total carbohydrate content of meals and snacks is the major determinant of the pre-meal insulin. So you see this one. The meal comes ahead of the calculation. Because sometimes they give the insulin, when you calculate the food, the person cannot eat it. It's plenty. The carbohydrate becomes huge. And you don't know how you can model that food for the patient to eat. Meanwhile, the doctor is only looking at the rising insulin, the rising sugar, and it's just increasing the insulin. He said that we must give the food that will be comfortable for the person, and that must be the determinant. So if you are giving 150 grams let's say, if you are giving 75 grams of carbohydrates for a lunch, that will mean you need 5 units of insulin to cover. If you are doing 15 grams per insulin, right? So, oh, it's not 5. Yes, 5. It's 5. So please, and that is where the discussion with the doctors is important. The doctor wants the sugar to come down. The boy is suffering. The girl is suffering. But the insulin is too high that the food is too big. The girl cannot also eat and will go into hypo. And every time there's hypo. I had one case in Tema General. The case, when I was writing the food, the girl opened her mouth. Am I going to eat all this food? But the reason why they came was persistent hypoglycemia. And the insulin level was, the insulin injection was so high. But according to the girl, said, I eat a lot. But when I did the assessment, she was actually eating, but it was still below the insulin. So we need to speak to the doctor, then we arrange, then everything will be fine. Good. So in a case where you can't find a doctor, what do? You must find a doctor, right? You must. Because there are some calculations, after you do the calculation, there are some fufu, that 12 yard, you cannot eat it. If you calculate that amount for that insulin, you cannot eat it. So, and especially those with mustard and pre-meal, so they do mustard, then at every meal you are taking. The dietitian, you must do your work well. Otherwise, you let somebody fall into coma one day. All right, let's move on. My slides are not getting finished. They must finish. Type 2. We see a lot, about 95% of the cases we see are type 2. So nutrition recommendation for a healthy lifestyle for the general public are also appropriate for type 2. As I said, healthy meals are The balanced meal is the diabetic diet. Whatever the healthy population can eat, the diabetic can also eat. Reduce energy intake and increase energy expenditure through physical activity of healthy weight loss. So physical activity, physical activity, physical activity. These strategies should be implemented as soon as the diagnosis of diabetes is made. When we get somebody who is freshly diagnosed, we have a very good chance of making very great impact in the lives of that person. Okay, so let's use these strategies for them. Right. Expert consensus on children and adolescents with diabetes. Individualized food, meal plans, and intensive insulin regimen can provide flexibility. I think I've discussed this. The key thing is that type 1 diabetics are growing. Most of them are growing. And when they are finished growing after 22 years, then we can try to see what we can do. But whilst they are still growing, we must not let them become midgets, or how do you call it? Stunted, or not stunted, malnourished. Okay, pregnant and lactating. How many of you have been frustrated with your gestational diabetics? When you come, the doctor said this thing is, go to the dietitian. This thing is high. The baby will grow too big. The sugar must come down. When you come and you check, this person is drinking 1 Coke in the afternoon, 1 Coke at night. That one alone is giving you like several servings of carbohydrates already. We have said that we will not take it away. But if you allow those 2 Cokes, then the person can only eat 2 slices of yam the rest of the day after your calculation. So it becomes a challenge. Will you give the 2 Cokes and 2 yams? How are you going to meet it so that the person's sugar will drop for the cesarean to go on smoothly or others, right? In fact, until recently, I have been very frustrated with it. I get a lot of gestational cases sometimes, and the second trimester one is the tough one. The third trimester, they will tell you, oh, we are going to give birth, so whatever food you give us, we'll do. But second trimester, say, am I going to do this for the rest of the 3 months? So you putting yourself in the shoe, it becomes an issue. If you give too much glucose to the person, the doctor, because around that time too, they can't give much medication. Limited. Diet must work. So you have to talk a lot to the people. Explain to them why the glucose might be low, and it will help. Unless a woman begins pregnancy with depleted body reserves, energy needs do not increase in the first trimester, right? During pregnancy complicated by diabetes, medical nutrition therapy is also important in achieving and maintaining optimal glycemic control. So this one too, you and your doctor, you must be talking. You must be talking. Sometimes they don't have one doctor, but whichever the doctor is, talk to them. Additional 300 kilocalories are suggested during the second and third trimester. This one I know. These are information we know already. In addition to adequate energy intake, pregnant women need to eat a healthy diet with adequate protein, 0.75 grams per kilogram per day, plus an additional 10 grams per day, right? So when you do 0.75 per kilogram, the calculation you get, you add 10 grams to it to be the total protein for the day. My time is up. Okay, all these are known. Gestational. Nutrition therapy for gestational diabetes promotes nutrition for maternal and fetal health with adequate energy levels of appropriate gestational weight gain, achievement and maintenance of normal glycemia and absence of ketones. Very important for the mother and the child. %30 caloric restriction of estimated energy needs appears to reduce mean blood glucose. So if the person comes and you do the assessment and he's taking 2,000, 30% of 2,000 is what? 600. So the person will have to eat what? 1,004. When was the last time you did a 1,004 diet? And this is the issue, because sometimes I do 1,000, 2,000 for very bad GDL case, and you see that the mothers are not happy. So you mean that when I sleep, I cannot get up to drink cocoa. Hey! Then they shout. But we need to do that to help them. So engagement. Not the one to marry, but the one to understand that their situation will be better. Especially when we know that if we don't tackle it well during the pregnancy, even if you get better after delivery, they have some questions to answer later. Yes. Yes, please. Yes. Yes.
Usually, what's not any morning, try what I do, try cut down on the carbohydrates in the food.
Okay.
That affects the
Okay.
and there are even some evidence that is backing
Reduce carbohydrates in the morning. Okay. You spread the rest. So let's say, so in this case, in the morning, how low will it be? Like in terms of grams, so that we all learn and take it.
Yeah, so usually about 30 grams minimum.
30 grams.
About 30 grams, that's 2 servings.
2 servings of carbohydrates.
Yes, in the
one
morning.
slice of bread and 1 soup ladle of oats.
So in this case, we are not doing, you have to bargain with the client, the
clients.
patient, that we'll take bread off, but then we are going to give you something that will fill you up.
So oat and veggies.
And then your protein.
Chew it like that and drink it on top.
No. So you have your protein, you have some avocado pear in your.
Yeah.
So
once you reduce carbohydrates, you can increase the others.
Then you increase the others so that it balances up. So what usually works very well for us, especially if it is just a single, if it is not twins and it's just single, what usually works for me is the 30 grams in the morning.
This
and it helps a lot.
It's rated.
This is expert opinion. This is practice.
Yes. Okay, thank you very much. Yes.
So I have a question.
Yeah, a question.
Yes. So
okay.
I'm not a gestational diabetes expert, but recently I've been getting a few gestational diabetes cases at hand. So I saw a certain woman, she was very, very obese, even in her pregnancy. And it was during pregnancy that she gained all that weight.
Okay.
And her intake was quite a lot, involving a lot of snacks.
Okay.
So I educated, she went away. She came back in a month's time and she had lost 4 kilograms, Okay. And I know pregnant women, the thing is you slow down the weight gain, but you don't cause them to lose weight. So I asked her if she was feeling like she's starving or she's getting hypos, and she's not getting any of them.
Okay.
So she just took away the soft drinks, like you were saying, all those things that she took away. And then she lost weight. So the doctor saw the weight loss. So she lost 4.4.
Okay.
Saw the weight loss and sent her back to me that I should check and she said she's not hungry. And she wasn't starving. Listening to the thing, there were some of the foods, the calories were small, but I corrected them a little, but she wasn't starving and she wasn't getting hypos. So did I do a very bad job, or sugars were fine? Sugars were fine. So I want to know what those like experts' opinion, what I should do. So I actually had to increase a little because some of the foods I realized she eats too little, but then most of them were okay. So
good. So if you look at this one, lifestyle modification aimed at reducing or preventing weight gain and increasing physical activity after pregnancy is recommended and can reduce the risk of subsequent diabetes. So 1, preventing weight gain in pregnancy must be looked at from 2 fronts. Now, the person who's eating more than required, because this person has crossed the threshold of healthy weight and has added a lot more. And even in maintaining a given weight gain will mean that the person will keep on increasing the meals for you to be increasing the weight. Because if you are, let's say, 120 kilogram in pregnancy, and even though your weight should have been 85 and you're 120, and you maintain let's say 3,800 calories, you will be 120. But if you come and every day you are increasing by 2 or 3, it means that you are going 4,000, 4,200, going to 5,000. So what I'm thinking you are saying is that after explaining healthy eating, she's now eating an amount that is maintaining an already high weight. Okay? It's because even if you lose 5 kilos from 120 and you come to 115 and you are supposed to be 85, you have still gone so way behind or beyond where you were. So if the person resort to healthy eating, not restricted eating. So let's say if you actually did it and the person was having 3,000 calories and you brought the person to 1,008 and it's reducing, we are doing a disservice to the person. But if it's about food choices, because it's one of the goals, help the person to make healthy food choices. And if the food choices is actually pushing the laden fat to support him or her, we haven't done wrong. We haven't done wrong. If he said, oh, you were 120, please, you need to come to 110. Yes, that is not a goal. That's not a goal. Better. Yes. Healthy eating can give mindless weight loss. Mindless weight loss. If he was underweight, then we would have had an issue.
Usually, the doctors, they check the weight of the baby. Yeah. Just for you to have that, your conscience clear that it is not the baby that is reducing. You just ask, you can ask the specialist to request for that.
Yes. I think we read one thing here.
Also.
He said that
they will check the baby's weight and then you are okay.
The baby will. Yes, the fetal weight. Now, is there an evidence for an appropriate weight mother or overweight mother who could have fetal weight loss? Is there an evidence like that? Because I would have been happy to see it. So that because usually if the person has stores, that's what the baby actually realizes, even if the mother is not eating. Until the stores deplete, then it affects the baby. So if the mother was actually eating healthy meals, but has taken away high caloric unhealthy meals, and it's giving us that result, the baby would have even been clapping. All right. Let's finish this. All the rest, you can read it. It's understandable. So conclusion, the current outlook of diabetes as well as future projection in the world, Africa, and for that matter, Ghana is dire, as we saw in the introduction. Medical nutrition therapy provides a critical opportunity to prevent or treat diabetes. Dietitians should be very mindful of the current evidence in order to provide relevant nutrition care for diabetics without compromising on their quality of life. Very, very important. Don't let the person leave your office and go and cry. So, thank you. These are the questions for discussion.
For a very seasoned presentation, we will open the floor for questions. And because of time, we want you to be as concise as possible, and then the resource person as well, so that we can finish quickly and then leave this place. So thank you. If you have a question, you are free to ask.
If there are questions online, you can ask them so we can answer.
Is anyone with a question can unmute and then ask a question or raise up your hand or type in the chat box. Any questions, please?
Those of us who are here, they will write physical, don't like online forms. Yes, Rosa, great presentation. How do you baby? Please, any advice on diabetes and fasting? Yeah. Hey, what happened? I think as I reviewed the evidence, I didn't see that. Okay, diabetes and fasting. Any idea? I just finished Ramadan. Please, diabetes and fasting. Any advice on diabetes and fasting?
There are evidence that is showing that our kind of fasting we do, it is a type of intermittent fasting for Muslims.
Okay.
And it has a lot of positive benefits for diabetics whose sugars are well controlled.
Whose sugars are well controlled?
Yes. If your sugar is well controlled and you, before the fasting, you contacted your dietitian and you had some prior discussion with your dietitian, you have positive outcome.
So in that case, the person can eat early morning and late evening.
Exactly. And I had some clients who are diabetics and they fasted.
Okay.
The sugars are fine. The only people we have coming on admission with high glucose levels are the people who do not visit their dietitians often.
Okay, so they don't have good control.
Yes, so they don't have so they don't have good control. And even those with good control, they need to be monitored.
Yeah, you have to have a chat with your dietitian.
Yes, you have to have a chat with it, then a plan.
So that in case within the fast, if anything happens, what you must do.
Exactly.
Okay.
Exactly. And even during that long month fast, you give them 2 weeks review.
Okay.
And that really helps.
Okay. So Ardi and how about the Christian fast? Can diabetics fast? And which type can they do? Because I know that the Christian fast is a lot. We have the Daniel's type of fast. The Ardi Daniel is here. we have the Daniel fast, the Esther fast. The Esther fast is no water, no food until the fast is over. The Daniel fast, you take away the choices meals. So if you like watching, if you are going to fast for 3 days, you won't eat watching, you eat fufu. If you like me, you know, fufu, if you take it, I've actually fasted. So you take the choices meals out so that you can have time to pray. Okay, so maybe some people will be chewing a broad and cutting meal. It's not to say it's not a good meal, it's a good meal, but that is not their choices meal. So they'll be chewing that. Some will be chewing gari like that and drinking water. Some that is some will be on vegetables alone, only vegetables and water. Yes. So that is the Daniel fast. And so for diabetics, they definitely cannot have the Esther study. No food, no water for 3 days, for 2 days, not even for a day. Right. So, and I always say that even the type of meal we do in diabetes, it qualifies to be a medical fast because of the cuttings we do. Somebody is to take 3,000 to there is 1,008. Right. So as Adi Hamda said, all the diabetics anytime you want to engage in any type of fast, speak to your dietitian and get appropriate advice. That's what I can say. So Rosa, that will be my advice.
Type of advice they give, especially to the Muslims. What type of advice the dietitians give? Like when they come and see you, what did they talk about?
Okay, yeah. So that if a Muslim comes to your clinic, you know what to tell the person. How do you have been advising them?
Yeah, so it is not only RD Handa who advised. Is it because I'm a Muslim?
Oh, but I've seen several cases.
Yeah.
Yes, in private practice.
So with the advice, it's individualized.
So some you actually tell them they shouldn't, right?
They should do what?
Shouldn't fast.
Yes,
Some
yes. Depending on your assessment, you will tell them that they cannot fast. But if you assess and you realize that, oh, this patient, the control over the past 3 months, over the past 6 months, it's been consistent, then per your assessment, then you can advise. So the advice during fasting period, we have pre-dawn meal, and the pre-dawn meal is mainly the healthy choices that we recommend. A high fiber complex carbohydrates with your protein and then some fluids. So based on how much you are giving the patient, that is why I said individualized. Then you are able to tell your client the pre-dawn you can have maybe 3 soup ladles of maybe fonio or your porridge, or the client will want to do herbal tea or green tea. So then you will ask. So if you are giving 2 servings of carbohydrates, then you can give your client just 2 slices of wheat bread with some vegetable stir-fried with some protein in there. So it's individualized. So and it is a healthy eating guidelines. That is just the basics. So
because of the Mohammedan fast, there are a lot of work that has been done there.
Yes.
With its impact on sugar, its impact on lipids, its impact, yes. So you realize that it will be, the person will miss one of the 3 meals and eat the 2 meals at times beyond the usual 6 to 16 we give. That's what happens.
Yes, that's
right. So I will also encourage all members. There are a lot of published work there. Diabetes, lipid profile, and Mohammedan fast.
So then just to conclude, so the basics is just a healthy eating guideline. You will not leave the client without giving portion sizes. That is the individual goal, how much you are giving there. So you give your portion sizes, and then morning and evening. And then, we have, it is a sunnah, it is a blessing to break the fast with dates. And dates are packed. So instead of maybe, so you can just say you have just 1 date, because 1 date will give you between 40, just the size of the date, it depends. So 1 date will give you between 20 to about 60 kilocalories. Okay. So if it's a diabetic, you ask the patient, instead of having 3 dates, it starts from 1, they are odd numbers, 1, 3, 5, 7. Some can eat as, when you break the fast, you know how hunger. Yeah.
And this too is nice.
Yes. So you just have to. So you have to factor that in the total carbohydrates. Exactly.
So, but do you collapse the 3 meals into 2 and divide morning, evening for them? In terms of, let's say, if the 210 grams of carbohydrate for the day, that he was taking 70. Do you now do it 105, or you still maintain 70 evening and exempt the afternoon?
So again, the day fast, you look at the person, you factor in the person's activity level. So if the activity level is high, that will require that you will have to look at that one also. And that will take care of it throughout the day.
I think this one is helpful. Next year's fast, we'll send clients to all your places. No.
Fast. So I want to ask about that one.
But I don't think they are allowed. They don't allow.
The Quran is so strict on that. You shouldn't fast. After delivery, then you can fast. But you have women who will tell you that they are so religious, they have the kappa to fast. So it doesn't help because you know the pregnancy with its associated nutritional issues. So you just have to explain to them.
Okay. Banana, I saw Nana.
So what we need to do as an academy, because this is a yearly something that we do, we can get a guideline that will help.
I think it will be helpful.
Yes.
Okay. We'll work on that.
All
it
right.
means that
thank you very much.
We need to also collate all the papers and publications and get something out of it. Evidence-based. Yes.
All right. So we'll take last two questions from Nana and RDPK. So Nana, is it? You can unmute and talk on Nana. Hello, Nana.
Is it Nana or Nana? We have the Nana at BRE.
Hello, please, you can unmute and talk.
Otherwise,
RDPK, if you are still going to ask a question. RDPK, do you still want to ask a question? Nana, you can unmute and talk.
Are you sure they can? Oh no, they can't. You are counting them.
When I click it, you can.
Okay. All right. I think. Okay. Then, if they are not asking, please close it. Has today's seminar challenged you to take care of your clients differently than today? Is there any way you took care of any patient that you have heard something today, you thought that you were not fair to the patient?
Yes.
Okay, so what have you learned today that you wished you knew before today? After today's seminar, what are you going to stop doing? What are you going to continue or start doing? And what are you going to continue doing? What will you stop? What will you start? What will you continue? It can be a rhetorical question. Let's answer it and let our patient be happy with us. Thank you very much.
For such a succinct presentation. For the sake of time, we shall have no break. We'll be moving on to the next presentation. And I'm happy to introduce to you our next presenter. So our next presenter holds a Bachelor of Science in Community Nutrition and then a Master of Science in Human Nutrition and Dietetics. She has 12 years working experience in pediatric nutrition, as well as malnutrition management, growth monitoring, conduct operational processes, and then anemia. She works with the Tema General Hospital. She is actually known for her innovative ideas in nutrition. Ladies and gentlemen, I present to you Mrs. Joyce Asari. Let's put our hands together for her while she comes to man the food.
Told my people to join the nutrition. Good afternoon. My senior police. Oh, okay. I think I have some of my nutrition people online, right? Okay.
Yeah.
Innovative complementary feeding. Why that topic? Innovative complementary feeding. A lot has been done in the area of complementary feeding. We have a lot of policies guiding our counseling and all that, but still malnutrition is on the increase. So what is happening? My slides are brief, so I think we are going to talk more. So be more of discussion. Complementary feed, is there something new? No. Over the years, we have a lot that has been printed in the maternal and child health record book. So let's see what is new. So by the end of the presentation, I just want you to understand the cause of malnutrition in your community, in your setting. Please, do I have some of the RDs seeing more of the pediatric cases? Okay. Then, oh, okay. Then we have to be able to give them the appropriate nutrition counseling. We always counsel them, but why is malnutrition still increasing? Then you also have to try and provide the necessary nutrition intervention. So globally, 1 in 3 children under 5 are not growing well due to malnutrition. And then almost half do not eat a diverse diet with fruit, vegetable, egg, and so on. But we always counsel them on diet. So what is happening? The quality of children's diet is more important, we all know, before the age of 2 years and even beyond. Then insufficient nutrients can irreversibly harm a child's development, which we all know. And there are a lot of evidence to show that 48% of children aged 6 to 23 months are not fed often enough. So we'll get to understand that more. The parents bring big bowls, prepare their food, the foods are not nutrient dense. You ask and I Google online and I was told or I read that you can give this food to, when you are starting, you have to give one food for some time before you move on. So we are there as experts to guide them. 2 in 3 children aged 6 to 23 months lack this diverse diet. Because of what I said, they come to you and they tell you, oh, I've started giving this cereal. And I read that when you are introducing the new food or you are starting complementary, you can give them maybe, if it's porridge, millet porridge, you have to do it for a week. Then before you start introducing other foods, when you ask them the reason, they have nothing to tell you. They've just read it online. So we need to do more in terms of our counseling. Then 340 million children suffer from hidden hunger due to lack of essential vitamins and minerals. So causes of malnutrition. We've seen this conceptual framework for so many years. So now in our settings, what I want us to look at is the immediate causes, the underlying causes, and the basic causes. What is the cause of malnutrition in where we work, our communities? In Tema, I have got to know that Malnutrition there is not because they don't have money, but they don't have the time. The care practice. So in your setting, what do you think is the cause of malnutrition? Yes, RD physics. We've seen this right from when we start with our nutrition courses. They always put this there for us. Conceptual framework, causes of malnutrition from UNICEF and all that. Inadequate dietary intake. We have disease, immediate causes. We've read this over and over. We have our underlying causes, inadequate access to food, inadequate care. But in Greater Accra, let's look at this conceptual framework very well. What is the cause of malnutrition in Greater Accra? Come again. Knowledge, good. Then what again? In your setting, is it your hospital? The time, they basically don't have the time to feed them, okay? So we need to do more. So I was happy when this topic was given in a way, innovative. We all have a lot to share with them. The mother comes to you, tell you her challenge, or you see the challenge. After our assessment, looking at the growth chart and all that, what can we do? How can we modify what the mother has told us to help the child gain weight, to help the child grow well as nutritionists and dietitians? So complementary feeding, we all know we start after 6 months. Exclusive breastfeeding, we continue with complementary feeding. But internationally, they refer to complementary feeding as weaning. But I'll say with the public health aspect, when we hear more of weaning, we think of mother taking the child off the breast milk. But complementary feeding, we know they are supposed to add, they continue breastfeeding up to 2 years or even more. We won't waste time going through the definitions and other things. So transition to complementary feeding after exclusive breastfeeding. What is happening there? Introducing complementary foods too late may cause an infant to develop nutritional deficiencies, which we all know, because after 6 months, the breast milk is not enough to meet the requirements of this child. And also may have difficult learning to eat complementary food, which are being introduced later. You know, the child has taken breast milk for some time, and per the knowledge and researches, at 6 months, the child is ready to accept food. So if we don't start early, the child will have so many difficulties. When you counsel these mothers, they tell you a lot of things, and their reason is that because they did exclusive breastfeeding. But is that the reason? Because some of them didn't start well, or some of them started too late. They are waiting to come to the hospital for the nurse to tell them your child is 6 months, start feeding the child. And some of them don't even know what to give at all, especially when you meet the first time mothers. You ask them, what are you going to give to your child? Porridge. What type of porridge? Cocoa. That's all they know about porridge, cocoa. What will you add? If you are lucky, those who have gone online, they will tell you, oh, I'm going to add Nan1, I'm going to add, they can mention some of them. But most of them, cocoa, and that is all. Wentia, yes. Now they are moving on. Wentia, they've stopped. There's the cocoa, because we've told them Wentia, what is the nutrient in Wentia and all that. Now they are changing from Wentia, and they don't even know what to add to the food again. So when complementary foods are introduced appropriate to the developmental stage of infants, nutrient requirements are being met, which we all know. We won't waste time on that. So early introduction of complementary food. Sometimes you get these mothers, they are about to start work. When they don't have the information that they can even express the breast milk and store, you get them and they've already started complementary feeding, adding on foods to them. We know that per the WHO standard, in Ghana, let me go. In Ghana, we are starting complementary at 6 months. But we can also start at 4 months when the mother has genuine challenges. But it's left to us as nutritionists and dietitians to help the mother prepare foods that the child system can tolerate, the child absorption can go on well in the system and all that. So we need to help these mothers when they come to us. Exclusive breastfeeding, we are promoting that. But you get a mother who genuinely cannot do anything about it. We shouldn't leave them, say exclusive breastfeeding is 6 months, go and continue. But this mother has come to you because maybe she has started and she's even having challenges. Then we tell them, go and stop and do breast milk. You know that this mother cannot do what we are asking the person to do. So this child will come another time and we are expecting weight gain, still there's no weight gain. So with the nutrition aspect, we are doing a lot, but we need to be more innovative when it comes to our counseling and the kind of food we tell the mothers to give to their children. We say when the food is introduced too early too, it can even result in some allergies. So when a mother is about to start this, I don't know whether some of the dietitians, we are able to go to the RCA centers to counsel the mother or give a general talk on some of these things. We are the experts, so I'll plead with all of you to join us. It's a team. Join the nutrition team in the facility to do some of these counselings. Okay, it can also cause, when they start too early, we know that the child will definitely not be able, or the mother will not even have the time to give more of the breast milk. So it's not good for the child. The mother, normally they prepare this porridge without anything for the child. The child is, because there's porridge, this mother will not even have the time to breastfeed the child well. So this child will become malnourished at the long run. So late introduction. At 6 months older, we know when they are full-term infant, they are supposed to start complementary feeding at 6 months. Some of the preterm, when you talk to the doctor, they tell you because of the time, they need to do more of the formula or the breast milk for some time before this complementary food is being introduced. But we know that by 8 months, they should be developing the skills to even feed themselves in their way, even with the preterm children. When the mother starts right, by 8 months, the child should be able to take in some of this, most of the complementary foods, and the child will gain a lot of weight. We know that when it's introduced late, the jaw and muscle development that occur when an infant eats those complementary food at the appropriate age, even contribute to their speech. Okay, so if the introduction is not going well, it's either late or too early, it can affect some of these things. And even the child can reject food at some point in time when the child is supposed to be on appropriate complementary food. So recommendations when we are counseling the mothers, they come to us and as dietitians or nutritionists, we tell them, go and do this, go and do that, go and do that. We have to also think of, one, the developmental stage of the child, especially when it comes to the preterm children. That because the child is 6 months, it doesn't mean that automatically they should be fed so many foods or like the other normal children are being put on. The nutritional status of the children, what do we look out for? Public health, we do more of the growth charts. We look at the trend the child is growing and all that. But when it comes to these preterm children, please, we shouldn't forget that some, when they come with 36 and we are going by the normal growth chart scale, we'll end up giving them or recommending some foods that will not even help them. Their system cannot tolerate. So we have something we call adjusted age and month and all that. So you need to consider all those things when it comes to preterm children. Okay, we have to look at some coexisting medical conditions. You have a child with cleft palate. You have to look at how this child is going to even take the food, how the food, the positioning of the, is it a cup or whatever bottle they are using to feed this child. So if you have, the mother is able to afford everything and even the feeding position is not going well. I have a child like that. They are trying their best, they can afford everything, but the child is not gaining weight. So I went to them and I realized that even the way they are positioning the bottle to feed the child takes a little and goes off. and the mother complain of some of the food going through some other parts of the body, coming out through the nose and all that. So, yes. So you just have to tell them. So you have to look at some of these medical conditions and know the appropriate counseling to give to help the children gain weight. Social factors. What is happening to our mothers? So we shouldn't just be giving them all our poor we know at the school and all the poor we know as dietitians because we have to counsel them on their diet. Sometimes we talk more of their calories, but with their medical condition, how the child is growing and all that. If you give this quantity of calorie as you are saying, the mother tells you this child cannot even take a lot at a time. So how do we spread it across the day? What are we going to add to increase the density nutrient to make it more nutrient dense for the child to gain weight? Culture, ethnicity, and religion. Give the child this, give the child this. We need to have in mind the culture of the family, their ethnicity, the food that they are eating, some of the things they are not taking, to help us plan an adequate meal for the child. The food preferences as a family. At 6 months, what do we tell them? They should start with porridges. Porridges. This is a family, and they don't even take anything porridge. And you tell them to give their child porridge. And as I said, porridge is not only cocoa, but that is the knowledge most of our mothers have. They can even get their normal staple, teasers with their ayoyo. It has to be prepared in a way that the child can take some of this. So if everything has to be blended or they'll grind their ayoyo to mix in the soup, they just add their teasers. They stir it to become just like the porridge. And the child can feed. It shouldn't be only our cocoa, our Tom Browns and all that. Even the banku we are eating with the palm nut soup. We just have to check the pepper, the spice, and the children can eat.
Someone said cocoa is
what?
Banku eating with sugar.
Banku eating with sugar. It's cocoa. No, you know, when we talk of cocoa, we just have in mind that it should be the millet or condo with whatever. So banku eating with sugar, is it the blended banku with sugar?
No, he said that is the banku that
you add sugar to it.
He said the cocoa is the banku. They have made it salt.
Oh, okay. Oh, okay. Then
so
financial.
When talking about the porridges, we are saying that you can make the main food also like
porridge. Okay. So financial consideration. And in terms they come to you, what do you add? Or add not one? They will mention a whole lot of things. But looking at the mother, sometimes you don't need to listen to them in a way. You look at the mother and where maybe the client is coming from. She's just saying something to please you. So we do more of, you have to tell her more of the local food. How much is this canned or tin food that they are even adding to make up for the nutrient they are looking at? When they can add just granule paste, some fish powder, they can even modify the family food to meet the nutrient requirements of their children. So adequacy of complementary foods. Dietary diversity. They need to give diverse diet. But you know when they start with the complementary food, we don't normally recommend 3 or 4. Now what they do is, they come to you, you ask them, Winnimus. They don't even mention Winnimus, Tom Brown. And then now they will mention about 4 or 5 proteins. We said they should be diverse. So when they start, we always recommend that if it's rice, maybe you add some granule paste. We know there are some foods that can easily result in these allergies or cause allergies. So we shouldn't encourage them to be combining some of the foods at the early stage. Maybe the first 1 or 2 weeks of start. They shouldn't add all those things together. Now we are even saying that it's in the child health record. At 6 months, they are supposed to run some labs, the GAND CPD especially, for us to know some of the food that they are reacting to. Now they have this Cocoa Plus on the market. Mothers start complementary foods and they are adding. They are the soya bean base. The base is soya bean. So if they haven't run some of these labs, and they start giving all those things, adding to it, they come to us with a whole lot of complication. And by the time they realize it's dietary, whatever, it's too late. Some will say, oh, my children, when they start food, that is it. They see it as normal. You know, normally they don't pay much attention to the dietary aspect, the things they are including in the food of the children. So please, as dietitians, nutritionists, when they come, let's probe. Then now they come, where did you even buy it? The Winnie Miss now, everybody is producing Winnie Miss. Where did you buy it? Is it FDA certified? No. Or it's AED. And the taste. But they are forgetting that they are children and they are now learning how to adapt to some of these things, their system and all that. So when they introduce more of these things, it can affect the children. So avoidance of added sugar. Avoidance of added sugar. The mother who cannot take porridge without sugar will definitely add sugar to this child's food. But when they start eating, I always tell them that whatever you start the child with, that's what the child developed the taste for. So if you are giving porridge without sugar, but you are adding other granule paste and all that, the child will be used to those ones. And there's no need of adding so much sugar to the child's food. Then even salt. They are used to just porridge with even salt sometimes for taste. But at that stage, what does the child know? Or the child tastes bad, hasn't even developed so much to get some of this thing. So we introduce the children to some of this food. So please, for sugar and salt, we all know as dietitians, quantity, they are not even able to, they just add so much salt to this corn dough for you to taste, and you even taste the salt in it sometimes. So we shouldn't encourage them. We should rather think of how dense the food is in terms of texture, the nutrients and all that to help the child to meet the nutrient requirements. And we should avoid giving drinks or foods. Food with the drinks. Now we have a lot of drinks on the market. The child is drinking, the child starts eating at 6 months. You see this mother giving the drinks because they don't even have the time. They buy this so-called apple drinks and all that with a whole lot of names or special names. They think it's meeting their nutrient requirement. We have a lot to do as nutritionists and dietitians. So for calories, when we look at the child health book, the maternal and child health record book, we have 2 to 3 tablespoons to start with from 6 months. But you know, we do more of as dietitians, the emphasis on the calories. But when you have any mother who comes to you, I think they are more comfortable with that than the calories you give to them and all that. They get so confused. So we should come to their level, especially when we get the mothers. The public health aspect, let's try to put in some of those things. Just open their book, tell them for your child's age, the child needs maybe 2 to 3 tablespoons a day. And for we dietitians or a dietitian, you know that when the mother gives this food, you tell the mother to add this granule paste or other things, the child will meet the nutrient requirement. Okay, so we shouldn't confuse them with our calories as dietitians. Then for the bowl size, public health, that's what we use. We tell them 125 bowl size, 250 from 9 to 5 years they can. So those ones are there to guide our preventive aspect, our mothers, in terms of the servings for the children. So for legumes, you are saying they can introduce every food. They can give everything we eat at home. But when and how do they introduce it? We have our legumes there, can be introduced into infant diet as protein. Groundnut, how do you prepare it? We know we have the nanny. Let's share with them. Some of them can add you'll be there, you'll be like, and you'll be surprised some of the questions they will ask you. Let's be patient with them. But some of them are first-time mothers. They don't even know what to feed. Yesterday, I saw a client in my office, a midwife. Breast milk is not flowing. And you could see that the way she's expecting the milk to flow is not flowing like that. But you'd be surprised, a midwife, and excuse me to say, she doesn't have that knowledge. Say, at the early stage, the breast milk will not come baby, and even the child doesn't need enough at that stage. She was just crying. When we keep asking her, what is the problem? Yes. So when they come to us, let's have the time. We should be paid. We have the knowledge. Let's try to guide them on. So we keep. Yesterday I was like, "Why are you crying? Why? Just be patient. It will flow. It will flow." And the more I tell her it will flow, she's not convinced. She's not convinced. So we have to bring out some things to show this mother to assure her that the milk will flow. So please, the knowledge is there. We have it. But sometimes how we go about our counseling, when they come, because we are experts, we try to sometimes pour the knowledge on them, intend them, let's come to their level so that they will appreciate what we are telling them. For legumes, they don't need much. We should introduce in small quantity, 1 to 2 teaspoons. Okay, if it's porridge, because we are not sure of wherever they are procuring their groundnut paste, they should add it to the cereal or whatever they are preparing. If it's rice porridge, put it on fire for it to boil. Though we know most of the aflatoxins, we can't do away with it even with heat. But when they put the food on fire, some of the microbes that can be damaged by the fire, it will help than adding the groundnut paste directly to the food when the food is cooked. Okay. So we have our poultry and all that. There are so many ways they can add it to their food. Okay, so but we should be very careful as how they should be introducing. Egg, we know it's one of the things that can cause allergies and all that, peanuts and so on. So processing food, now they all come to us and they are blending all their foods. Blending. They don't even have the blender. Some of them, blend their man. They can just put it in the cup, mash it. They can just get this sieve that we are using, if it's porridge or whatever, pass it through it, and it will be a little smooth for the child to eat. And at the early stage, I don't even recommend blending at all for them. Manubanku and oku, and the mother will ask you, "Oh, men blend it. Should I blend it?" Some of the questions they ask, because they don't even know that you can just add it to it, mash it with your spoon, and it will be like the porridge. So we have a lot to do as dietitians and nutritionists. So for practical aspects, we expect them to practice. The hygiene should go well, and they should feed with spoon. Even if it's breast milk the mother is expressing, we want them to give with spoon, because we know researchers have shown that it brings a lot of confusion when they do with the teeth, the hygiene aspect and all that. So how innovative can we be as nutritionists and dietitians? We have a lot of banners, posters in our books and all that. Still, malnutrition is on the increase. So this is a research that has been done. Okay, now they have some of the foods on their plates designed, and I know dietitians, you have those plates already, the portion sizes and all that, and it makes it easy, and they appreciate it more. Public health, what are we doing? This is a research that has been done. They have the foods and all that, some of the foods on the plates. So the mother picked this plate and will even remember that, oh, okay, when my child starts eating, I can give some of these fruits or vegetables to the child's food, or I can add it to the child's food. Then in terms of, we tell them about the porridges, and what we normally say is it should be dense. We have a spoon in the maternal and child health record book. We tell them that when they tilt it, it should take some time for it to fall off the spoon. What they came out with, the researchers, that they have these slots on the spoons. So when the mother fetch this food with this spoon, when it's thick, it will take a longer time for it to come out of the spoon. So this is a research someone has done, and I can share with you. Thank you all for your attention.
Yes, thank you.
Mrs. Joyce Asari-Kisi for such a straightforward presentation. We shall open the floor for questions, and then the responses will come after. So if you have any question, you may ask.
All right. So, please, because of time, those of us online, kindly ask your questions as soon as possible. Another zone is waiting to use the platform, the Zoom platform, for us to move to that. Okay, so there will be a link in the chat box so that Southern Zone or those of us on this call will move to that link and continue from there. And then please, any questions? Those of us here, I think someone has raised their hand. Yes, please.
It happens, or the preparation of it, I mean, preparing mother and preparing child happens mostly at the from the CWCs. So the thing is that before even it comes to a dietitian's desk, most of the time, then probably there is one or two disease conditions that have, occasioned the child to be in front of you, or the mother to be before you, either at the ward or at the consulting room. My experiences with, and this comes from first-hand observations at what happens at some of the CWCs, are quite worrying, especially when the very tenets of the principles governing, complementary feeding, or preparing mothers and their children to initiate complementary feeding, it's most of the time not even factored into the work. I mean, you interrogate, and then the first thing you are told is the sheer size of clients they have to see for the day, which I mean, to be frank, yes, sometimes I see a lot of mothers and just see, and they have to be seen throughout the day. So they come even when they do the run-throughs, and what are you feeding the child? Feed them well. Buy the winning mixes and things they have on the tables, and then you move on and stuff. Meanwhile, like you're rightly saying, preparing the mother, preparing the child is key. And even as to issue of whether the child may be allergic and assessing for allergy and intolerance, all those things need to be done even before the initiation of complementary feeding. And when, how to prepare the mother. So, they go there almost every month. Nothing is said most of the time. Then 6 months comes, and then you expect the mother to know how to. So hence, they will have to probably wait to their next visit, which that time the child may be probably in their 7th or 8th month. That's if they miss any visit. And then you say, oh, you are late. Meanwhile, no preparation is done. And so for me, a lot of the work has to be done with the help of the is it community health nurses who are mainly in charge of the CWCs, have to be done in preparing the mothers and the children or the babies prior to the initiation, and the necessary information and how to combine the foods and consistency in thickness and feeding position, and everything should be part of the education that is given comprehensively before it begins. And once that is missing, then again we always will have the problem that we see. Thank you.
Is any more questions? Any more questions? Those of us here, those of us online. Nana, I've given you the opportunity to unmute, but it looks like
Yeah, please
it
ask the
doesn't
question.
happen.
And
Please
thank
hold
you so
on.
much.
Okay, please, you can ask your question.
Yeah, so thank you so much to all the presenters. My own is, I think it's a clarification. I'm aware on the malnutrition treatment management at the hospital. I'm aware National Health Insurance caters for malnutrition cases, as in, treatment. I want to find out, and I'm also aware that there's also adult malnutrition that NHIS is, catering for. I'll be very happy if Mrs. Kitty could just, talk, if she knows anything about it. How much is the charges, if it's the subsidy, the food, and that's, so that will also be addressed with this issue. But lastly, the recommendation that I want to make is, you see, breastfeeding, I heard, it's not just about saying it will come, keep on suckling. Sometimes there are some factors that also contribute to the mother unable to, breastfeed. So like the stress level, she's not prepared. So again, it's still boiled down to right from pregnancy. We should try to prepare the mother, give her enough education right from that. I think it will really help. Thank you so much. Please, I'm done.
Okay, with the malnutrition management, the last time I checked, health insurance is paying almost 400. So I don't know if you are talking about the therapeutic feeds. When we have free one, the therapeutic fees form part of their management, so it's free. But when there's shortage and you have to buy the things to prepare yourself, I think that one, it depends on the management of the facility. Okay, so you need to talk to the management. Now we don't have the therapeutic feeds in the system. So you need to talk to them. For general hospital, it's part of the bill health insurance is paying for. It's only when they are not on the insurance that we bill them. Thank you.
All right, thank you. Please, any more questions? Any more questions? Those of us online, any more questions? All right, thank you all very much. Please, over to you, moderator. Thank you, Mrs. Joyce Asare Kisi. We would have to end our online platform right now. Thank you all.